Hi, this is the video that deals with an important concept in the respiratory system. It's called lung compliance. I'm going to discuss this in two parts. First part would be the basic understanding of this concept called the compliance, and then the second part would have its clinical application. So let's understand this concept in the first video. The concept of compliance of the lungs. Basically, this word is used in normal English language as well. Compliance, we say the person is pliant, or compliant means if you say something and it's obeyed, something like that. So, what's the meaning of compliance? Compliance is a measure of distensibility of the lungs, measure of stretchability or measure of distensibility of the lungs as a tissue. You know, the lung tissue and lung parenchyma has been compared with nylon stockings. This is called as nylon stocking phenomenon, whereby one thread of nylon stocking is not as stretchable, but when it is woven into that nylon stocking or nylon socks, it becomes quite a stretchable material. So, similarly, in the lung parenchyma, each fiber or each elastin may not be that stretchable, but when it becomes the lung parenchyma, it's quite stretchable or distensible. So, compliance is a measure of that stretchability or distensibility of the lungs. Second point, and this is the important point that you must understand here, is that compliance is inversely related to surface tension. A very important aspect. Compliance is inversely related to the surface tension. I am talking about surface tension within the alveoli. You know, in the alveoli, there is a fluid that lines each alveolus, and therefore there is surface tension. So, surface tension causes shrinking tendency of the alveoli. Alveoli have a shrinking tendency. The lungs have collapsing tendency due to the presence of surface tension within the alveolus. And when we say compliance, it's inverse of that. Compliance is distensibility. So, shrinking tendency caused by the surface tension within the alveoli, and compliance is opposite of that, inversely related, that is distensibility or stretchability. You know, during inspiration the lungs have to distend, the tissue has to stretch. So, this one fact one should keep in mind, that surface tension causes collapsing tendency of the alveoli, whereas we are looking at the compliance, which is the distensibility, which is actually inversely related. Third point is that compliance is expressed as delta V by delta P. That is change in the lung volume per unit change of pressure around the lungs. That is how the compliance is expressed. Change in the lung volume per unit change of pressure around the lung. So, that delta V by delta P. This is how the compliance can be expressed, or compliance is expressed, that what is the pressure change around the lung, and for each unit pressure change, how much is the distension of the lungs. So, that is how the compliance is expressed. Now, That's a few basic points about the compliance. Let us now understand what are the types of compliance. The types of compliance. There are three types: static, specific, and dynamic. Static compliance of the lung. Imagine lung as any other tissue in the body. Forget about this fact that the lungs are constantly inflating and deflating. Inspiration, expiration is going on. Lungs are constantly in this motion, inflation, deflation. Forget about that. Just imagine lung as a stationary tissue, just like any other tissue. Or take it outside the body and see how much is it stretchable, how much is it distensible. That would be called as static compliance of the lung. And static compliance of the lung is about 200 ml per centimeter of water. 200 ml per centimeter of water. See, delta V by delta P. So, it means if the pressure around the lung is changed by 1 centimeter of water, distension of the lung would be by 200 ml. We inspire air and the lungs distend during inspiration. So, how much is that distension? This is that static compliance of the lung, which tells us how much will be the distension of the lungs. For every 1 centimeter of water pressure change around the lungs will distend with 200 ml of air. So if the pressure is changed by 2 centimeters of water, 400 ml distension during inspiration. 3 centimeters of water pressure changed, 600 ml distension. That is how we can express the static compliance of the lung. In fact, let me also add here, intrathoracic pressures or intrapleural pressures, the pressure around the lung. At the start of inspiration, it is minus 5 centimeters of water, and by the end of inspiration, as the lungs distend, the pressure becomes more and more negative, and by the end of inspiration, it is about minus 7.5 centimeters of water. So, what do you observe here? During inspiration, there was a total pressure change of, and I am talking about quiet inspiration, I am talking about quiet breathing, quiet inspiration. The pressure around the lungs changed from minus 5 to minus 7.5, means a total pressure change of 2.5 centimeters of water from minus 5 to minus 7.5. Now, consider this, that for every 1 centimeter of water pressure changed around the lungs, the lung distension will be by 200 ml. So, for 2.5 centimeters of water a change of pressure, how much will be the distension of the lungs? 200 into 2.5, yes, precisely, and that's 500 ml. This is called as tidal volume of our breathing. We inspire 500 ml, lung distension is by 500 ml of air as we inspired that air. So, this is how the things happen, that pressure around the lungs will change by 2.5 centimeters of water, and the distension of the lungs would be by 500 ml, because for every 1 centimeter of water pressure changed, the distension is by 200 ml. That's a static compliance. Now, here I was talking about compliance of the lung alone. If I consider lung plus thorax together, this is an entire system. A thoracic cage expands, then the pleurae will move and the lungs expand. So, if I consider lung plus thorax together, the compliance becomes half, that is 100 to to 110 ml per centimeter of water. If I considered lungs alone, it would be about 200 ml per centimeter of water. If I consider lung plus thorax together, then the compliance of this entire system, the distensibility of the entire system would be just half of that. That is 100 to 110 ml per centimeter of water. Now, why is that? That is because, remember this, that the thoracic cage and the lung has opposing tendencies. The thoracic cage has got a tendency to move outward. Its natural tendency is to move outward. When the thoracic cage muscles contract, the thoracic cage will move outward. So that's a natural tendency of the thorax. Whereas lung has a natural tendency of collapsing. There is a surface tension within the alveoli, and therefore alveoli and the lungs have a natural tendency to collapse or inward recoil tendency. So you see, lungs and thorax, they have opposing tendencies, and because they have opposing tendencies, when we consider them together, the compliance of this entire system becomes almost half of the compliance of the lungs alone. So remember, when we consider lungs alone, the compliance is 200 ml per centimeter of water. If lungs plus thorax together, they have opposing tendencies, and therefore the distensibility of the entire system is reduced to just half of what it is for the lungs. That's called as the static compliance, the distensibility of the lungs. Now, second type of compliance is specific compliance. Specific compliance. It is taken as compliance upon functional residual capacity. Compliance upon functional residual capacity. Let me just explain this part. What is functional residual capacity? The amount of air that remains in the lungs at the end of quiet expiration. At the end of quiet expiration, the lungs are at functional residual capacity. It's called functional residual capacity, and we can say that when the lungs are at functional residual capacity, FRC, it is the equilibrium position of the respiratory system. At the end of quiet expiration, remember, at the end of quiet expiration, the respiratory system is said to be in equilibrium position of the respiratory system. Why is that? That's because at the end of quiet expiration, those two opposing tendencies which I mentioned just now, the thoracic cage has a tendency to move outward because thoracic cage muscles will contract, and the lungs have inward recoil tendency. Let's just draw it here. The lung has inward recoil tendency, which is their natural tendency because of the surface tension within the alveoli. The alveoli have a collapsing tendency, whereas thoracic cage, this is a cross section of the thoracic cage. Thoracic cage has got a natural tendency to move outward. At the end of quiet expiration, the thoracic cage muscles will contract and it has a tendency to move outward. So these two are opposing tendencies, and at the end of quiet expiration, these opposing tendencies, they cancel out each other, and therefore we say that the respiratory system is in equilibrium position at the end of quiet expiration, or at the end of quiet expiration, the lungs are at functional residual capacity, the amount of air that remains in the lungs. Now, What is the explanation of all of this? Specific compliance. It is something like a cardiac index. If you have read about cardiac index, we will discuss it in some other video. What is cardiac index? Look, 5 liters per minute is the cardiac output. Suppose every individual at rest has got a cardiac output of 5 liters per minute, means 5 liters of blood circulating through the body per minute. Okay, fine. For every individual it may be true, that's right. But imagine a newborn baby whose heart is pumping 5 liters per minute and that much amount of blood is circulating throughout the body. And imagine an obese adult, even his or her heart is pumping 5 liters of blood every minute and 5 liters of blood circulating throughout the body. But that circulation of blood is for how much body surface area? It is for how much tissue mass? I mean, see, for a small newborn baby, that 5 liters of blood circulating throughout the body may be too much. And for an obese adult whose heart is pumping 5 liters of blood per minute, that 5 liters is circulating through the entire body, which is a huge body mass or huge tissue mass. So it may be inadequate. And therefore, cardiac output should be seen in the context of for how much body tissue mass it is circulating. So that's called as cardiac index, cardiac output per meter square of body surface area. That is, that cardiac output is for how much tissue mass, how much body surface area. Similarly, now I am taking that concept here as a parallel. Okay, we have a compliance of 200 ml per centimeter of water. That's the distensibility of the lungs. But it is for how much lung mass? It is for how much volume of the lung? That is to be considered, for how much size of the lung and how much therefore by implication body size that compliance is being given. So that would be called as specific compliance, that compliance upon functional residual capacity. See, in a newborn baby, its lungs may have same distensibility as maybe an obese adult, but the lung sizes are different and therefore functional residual capacities of these two cases would be different, and therefore that compliance, that distensibility of the lung is for how much lung size. That's called as specific compliance, compliance upon functional residual capacity. Now, next, the third type of compliance, and this is by far the most important part of this discussion, is dynamic compliance of the lung. Dynamic compliance of the lung. Look, we have said just now that static compliance means the lungs were static, lungs were stationary. How much will be their distensibility? And we said 200 ml per centimeter of water. Quite a linear relationship we have said just now. Means if we change the pressure by 2 centimeters of water, the lung distension will be 400 ml. If the pressure changed by 3 centimeters of water around the lungs, distension would be 600 ml. Quite a linear relationship. But inside the body, when the lungs are constantly in the movement of inflation and deflation, this relationship does not remain very linear. This delta V by delta P relationship does not remain linear. So what is dynamic compliance? What I am trying to say here is changing compliance with the stage of breathing. That is called as dynamic compliance. This delta V by delta P goes on changing during different stages of breathing, and that's called as dynamic compliance. What I'm trying to say here is that at some stage, for a small pressure change, there would be good volume distension. We are talking about changing delta V by delta P. So, at some stage of breathing, at some stage of inspiration, for a small pressure change, for a small delta P, there would be a good delta V, there would be a good volume distension. That means the compliance is good. And at some other stage of breathing, at some other stage of inspiration, for a large change in pressure, there would be a small volume distension. We are talking about delta V by delta P. So, for a large pressure change, if there is a small volume distension, that means compliance is not so good at that stage of breathing. So, this changing compliance with the stage of breathing is called as dynamic compliance of the lung. Let me explain this further and recall that compliance is inverse of surface tension. Let's just recall that, and now let me explain these two sub-points in this particular part. A, at the start of inspiration, when alveoli are small in diameter, you know, because alveoli are not filled with air. Which means what? Which means surfactant molecules within the alveoli are concentrated over a small surface area, over a small area. The surfactant molecules are concentrated. This is at the start of inspiration. Alveoli are not filled with air. They are small in diameter. So, surfactant molecules are concentrated over a small area. And because of that, the surfactant is efficient. Surfactant is efficient in reducing the surface tension, because the surfactant molecules are concentrated and their job is to reduce the surface tension within the alveoli. Therefore, surface tension will be less, surface tension will be reduced dramatically, and we have already said compliance is inverse of surface tension. So, if the surface tension is low, that means compliance would be high. Yes, compliance is high. The delta V by delta P relationship we are talking about will be high. That means what? That means for a small change of pressure, there will be a good volume distension. So, just at the start of inspiration, just a small change of pressure around the lung and the lungs would distend with good amount of air, good volume. So, remember, at the start of inspiration, the compliance is high because the surface tension is low, and that's because surfactant molecules are concentrated. Well, this is said to be near the or at the lower lung volumes. Remember this part, that at the start of inspiration, or if we have expired out forcefully, we are near the lower lung volumes. Means what? Less amount of air is remaining in the lungs. We say the lungs are at the lower lung volumes. And when we inspire, either quietly or forcefully, we take in the air into the lungs. That means we are going towards the higher lung volumes, because then more and more amount of air is present in the lungs. We will say we are near the higher lung volumes by the end of inspiration. Right. So, remember this, at the lower lung volumes, at the start of inspiration, the compliance is high. Now, point 2. The next point, point B, is that by the end of inspiration, see what is the situation. Now that you have inspired the air, alveoli have alveolus increases in the diameter. That means the surfactant molecules are scattered now. Look at this alveolus and look at this alveolus. Now the surfactant molecules are scattered because now alveoli have become large. So by the end of inspiration, that means alveoli are large in diameter, surfactant molecules are scattered. That means the surfactant is less efficient now in reducing the surface tension, and because of that the surface tension is high. At the end of inspiration, the surface tension will be higher because surfactant is scattered now, surfactant molecules are scattered due to inspiration and enlargement of the alveolus. So surface tension is high, and we have already said compliance is in inverse of surface tension. So if the surface tension is high, that means compliance is low by the end of inspiration. Compliance is low. We are talking about delta V by delta P relationship. So compliance is low means what? Compliance is low means there would be a greater pressure change and the volume distension would be less. Pressure change around the lung would be more, and for that pressure change the volume distension will not be that great. So compliance is reduced now. That's a reduced compliance. For a great pressure change, there is a small volume distension. That's a poor compliance. Imagine that's by the end of inspiration. Sometimes an analogy is given for this, the balloon analogy. That is, when you are trying to blow a balloon, at the start of this, for a small application of force, the balloon distension is good. And when the balloon is already filled with gas and the balloon has enlarged, then you have to apply more force, but the distension of balloon becomes less once it is already filled with air. So that is not a very perfect example, let me say this. It is just for you to kind of visualize this part, that at the start of inspiration, for a small pressure change in the lung, there would be good volume distension. And by the end of inspiration, the more pressure changed but less volume distension can be seen in the lungs. So that's the dynamic compliance, and as I have already mentioned, this is at the higher lung volumes. So remember, I have already mentioned this, that as you inspire and the air goes into the lungs, you are going near the higher and higher lung volumes. When you exhale out, you are near the lower lung volumes. Less amount of volume remaining or more amount of volume remaining, based on that we call either lower lung volumes or higher lung volumes. So near the higher lung volumes, the compliance is poor, it's less. Okay, now that is called as the dynamic compliance. So these are the types of compliance, and that's part A of this video. In the next video, we will see the compliance diagram, and we will also see the applied aspect of this particular section, the clinical application of the understanding of compliance.